The topic for discussion is cranial nerve examination. Cranial nerve examination is one of the most important systemic examinations when patient enters to us because some cranial nerves, some of the disorders can manifest as this cranial nerve defects, and here we can see various the cranial nerves that are present. 12 cranial nerves, that is optic. The first one is olfactory, optic nerve. Then we have oculomotor, trochlear nerve, trigeminal nerve, abducens, facial nerve, vestibulocochlear. Then we have glossopharyngeal, vagus nerve, hypoglossal, and accessory nerves. These comprise the cranial nerves. The picture shows us the various cranial nerves that have been originating from the brain. And the cranial nerves examination will be following now. So before starting the cranial nerve examination, prepare the patient. Make the patient sit comfortably on the chair or on the bed and towards the edge of the bed. First examine for if patient is having any previous history of trauma, like such as scars or any cranial deformities or any facial asymmetry, pupil equalities, and search for any neurofibromas that are present, ptosis and proptosis. By examining these features can give us a insight whether the patient has already encountered some trauma or cranial nerve disorders, etc. So thus we can come to a diagnosis where we can actually go and search for we can investigate for those cranial nerves in examination. So coming to the first one, that is the olfactory nerve. Now olfactory nerve usually carries the sense of smell from the nasal mucosa to the olfactory bulb. Usually if patient does not give us any history of any disorder in the smells, the sensation of the smell, usually this olfactory nerve can be skipped, need not be examined. However, if patient gives us any history of patient is having difficulty in identifying various smells, then olfactory nerve examination has to be done. Usually when you are checking for olfactory nerve, first check for any deformity of the nose or any nasal diseases are present or any neural lesions are present which are in relation to this olfactory one. If there is any abnormality detected, then check whether if there is any impairment of smell, whether it can be unilateral impairment of smell or bilateral impairment of smell. And this picture shows us the olfactory system. When we are wanted to check for olfactory nerve examination, then you take few bottles of containing essences, and these essences should be known or be familiar with the patient already. So take some familiar order to the patient such as coffee, chocolate, lemon or asafoetida, etc. and you ask the patient to smell. If patient is able to by closing his eyes, ask the patient to smell and tell us what substance it is. If patient is able to tell us what it is correctly, then we can then the cranial nerve is functioning properly. Sometimes what happens is patient will be able to smell it correctly, but he or she may not be able to tell the name properly. So even then also the cranial nerve is functioning properly. Probably think about the patient may not know the name of that particular substance, so switch to some other essence where patient is familiar with the name too. Sometimes patient may not be able to smell, or he can also have a different sensation of smell for that particular substance, and this is called as parosmia. Parosmia is where patient will even when patient is given a pleasant odored substance, patient will feel that the odor is very stingy or not a very pleasant sensation there. So that condition is called as parosmia. And there is another condition called as anosmia. Anosmia is a condition where there is loss of sensation of smelling. Patient will not be loss of ability to smell. Patient will not be able to feel that smell. Okay, the sensation of smell. That condition is called as anosmia. There are various clinical reasons why the common causes for this anosmia, and they include patient may have a simple thing such as acute or chronic inflammatory nasal disorder, to a larger extended severe reasons such as head injury. Patient may be a chronic heavy smoker and they can also have intracranial tumor compressing the olfactory bulb, atrophy of your olfactory bulb, or chronic meningeal inflammation, and in some cases there can be a Parkinson's disease also patient where patient will manifest with anosmia. So that is about how we actually check for olfactory nerve, and also various disorders that have been encountered in case of olfactory nerve. And coming to the optic nerve is one of the important cranial nerve. All the cranial nerves are important, but this is one of the important because it takes the visual impulses from the retina to optic chiasma and into the optic tract to the lateral geniculate body. The impulse usually acts as an efferent pathway for the pupillary light reflex. Okay, here this is a visual system where we can see the various parts of the eye and how it has been taken to the optic nerve. For checking of this, the function of the optic nerve, we have to check for visual acuity, visual field, or any ocular lesions or neural impairment that has been present. So what is this visual acuity? Visual acuity is, in a layman's term, is a clarity of vision. It can be defined as the measuring of the spatial resolution of the visual system. Okay, so it will help us. Visual acuity will actually tell us how clarity the vision is. Okay, to test for this visual acuity, we have various tests which include standard Snellen's chart and Jaeger type card. Usually Jaeger type card is used for near vision. Okay, we can actually, it will be helpful to see the near vision, to measure the near vision. And standard Snellen charts is usually most commonly used for visual acuity, and this picture shows the standard Snellen's chart, and the patients will be able to there will be a chart displayed in front of the patient, and usually at a 6 meter distance, and patient is asked to read the lines there, the alphabets which have been present on the columns of alphabets. Patient is asked to read, and these alphabets are of various sizes, and based on the ability to read that particular line or that particular sized alphabet will be helpful in knowing the visual acuity of the patient. Now coming to visual field, measuring the visual field is nothing but how much is the periphery of your, how much periphery the patient is able to see. So visual field measurement will be used to chart the periphery of the visual field, and it will be used to detect the position, size and shape of the blind spot there. Normally this visual field, any visual acuity changes can be either because of your optical reasons or neural reasons. The optical reasons will most commonly include if there is inability of the retina to focus, the sharpness of retinal focus, or if there is any retinal diseases are present. And the neural disorders can include any optic nerve damage or any disorders related to optic nerve. Even these can cause changes in the retinal, changes in the visual acuity. Ophthalmoscopic examination. Ophthalmoscopy is visualizing the fundus of the eye, and hence it is also called as fundoscopy. This will be helpful in identifying any diseases within the eye, which will include the retina, iris, and also the fundus of the eye. Normally, any lesions of this system can include either total unilateral loss of the vision. This can be seen in case of optic nerve lesion, and there is something called as homonymous hemianopia. This hemianopia is usually because of a lesion between the optic tract to occipital cortex. Here what happens is patient will lose vision either on the right side or left side of the midline drawn vertically. Here in this case we can see patient has lost the left side of the vision completely here on both sides. The left half of the vision is lost. Coming to bitemporal hemianopia, it is usually when there is a lesion in the optic chiasma. Here what happens is it is like a partial blindness. Here in this case what happens, patient will not be able to see the half of the outer periphery will not be seen. There will be blindness in the outer periphery of system. This is called as bitemporal hemianopia. And when testing when you are testing for optic nerve, there is something called as swinging torch test. In this swinging torch test will be helpful in identifying the constriction, your pupillary reaction. So this will be usually done in a dark room, and the examiner will be taking a pen torch which is illuminated and will swing it across. So while swinging this pen torch or the light, with the reaction to light, the pupil will constrict. If pupil is not constricting, then it shows us that there is some defect. And in some cases what happens is, especially while measuring the acuity, we have various computerized tests are also available, like TR-ACT tests are available for helping us in measuring the optic, especially the visual acuity, and the peripheral vision, especially the visual field. Coming to oculomotor or trochlear or abducent, it usually checks for peripheral lesions or nuclear involvement of the pupils. Here we have to examine the eye movement and determine if the defect is of muscular origin or of the neural involvement, and it will also help us to detect nystagmus. Nystagmus is nothing but the to and from motion of the eye, right, which is usually a repeated to and from movement of the eye is called as nystagmus. Coming to the various tests, one is reaction to light. Here we can use the swinging torch test here also, and then reaction to convergence and accommodation of near vision, and examination of ocular movements such as lagging and nystagmus. You also have to analyze if the patient is having any diplopia, that is nothing but double vision. This is a picture which is showing diplopia and isotropic central vision suppression. Coming to the common causes of the paralysis that happens, which includes pontine lesions, neoplasms or tumor of the base of the skull, or any vascular accidents, demyelinating lesions, meningeal inflammation or increased intracranial pressures. Now coming to examination of trigeminal nerve, that is cranial nerve 5. It will be helpful in determining any sensory impairment, which is usually to determine the unilateral and bilateral motor response and to differentiate from and it will also be helpful in differentiating any unilateral or bilateral motor weakness. And most common tests that are used are superficial sensory assessment from mainly 6 areas. That is, here we can use mild light touch or small pinpricks. Here forehead to upper part of the side of the nose will supplied by ophthalmic. Hence we can test for ophthalmic branch of trigeminal nerve in these regions. And malar and upper lip region will be in these regions we can test for maxillary branch, and chin and anterior part of tongue will be helpful, are the regions where we can check for mandibular branch. Coming to the corneal reflex, reflex is another test for for the sensory trigeminal nerve, usually for the ophthalmic branch. Here what happens is we take a small cotton ball and just wipe on the cornea, and immediately we can see the reflex. In normal cases there will be a blinking of the eye. Corneal reflex or blink test is also called as. Normally it is consensual reflex, and hence when corneal reflex test is being done on one eye, the other eye also will start blinking. This corneal reflex is usually positive, and in case if there is any lower motor neuron disorder, especially Bell's palsy, in those cases what happens is corneal reflex is not usually elicited. Coming to motor assessment of muscles of mastication, which include biting against resistance and protrusion of mandible against resistance, will be positive in normal cases, and later excursive movements against resistance. There is something called as jaw jerk reflex. This jaw jerk reflex usually seen in upper motor neuron lesions. Here what happens is normally this jaw jerk reflex is absent in normal people, or it is very mildly seen whenever we tap the chin in a lower direction, okay, putting it in the downward direction, tap on the chin or under the lip. In case of upper motor neuron lesions, what happens is when the jaw is being tapped, the masseter with slightly opened mouth, when the jaw is jerked, tapped here, there will be sudden jerk from the masseter muscle causing closure of the mouth. This is called as jaw jerk reflex, and it is usually elicited if there is a upper motor neuron lesion, and in normal individuals jaw jerk reflex is usually absent. What are the common causes of this any problem of the trigeminal nerve, which includes tumor of the base of the skull again, any chronic meningeal lesions are present in case of any syringomelia, agnostic neuroma and multiple sclerosis, etc. Now coming to the examination of facial nerve, that is cranial nerve 7. Here it is useful to check any unilateral or bilateral weakness of the muscle, again upper motor and lower motor neuron disorders, and to detect any impairment of taste. So what are the various tests that are being done for cranial nerve examination? They include motor assessment of muscles of facial expression. So we'll ask the patient to do various facial expressions such as closure of eye tightly. So this will be helpful in checking for orbicularis oculi, closing the lips tightly, orbicularis oris. In case of blowing the cheek, which will be helpful in identifying the vaccinator muscle. So various facial expressions are being asked to do. The patient is asked to do all these various facial expressions. That is nothing but the motor assessment of the muscles of mastication. Examination of taste, where a patient is usually asked to taste various substances, like if the tip of the tongue, it is usually for sweet, and sides On the anterior sides, it is for salt, and posterior lateral edges is usually done for sour taste, and the posterior most part is usually done for bitter taste. So this is how the examination of taste is done. And then we have secretomotor function is also being done, and reflexes like various corneal reflex and nasopalpebral reflex is done. In nasopalpebral reflex also, when we actually tap on the nasopalpebral junction, patients usually blink the eye and it is also a consensual reflex, hence both the eyes will be blinked at a time. If this nasopalpebral reflex is negative, in those cases we can suspect some facial nerve defect. Then what are the common causes for facial paralysis? They include, first common reason is any neoplasms that is affecting the thalamus, Parkinsonism, Bell's palsy is the most common reason, and Guillain-Barré syndrome, any cerebrovascular accident or neoplasm, or will lead to bilateral upper motor neuron palsy. This is the picture which is showing Bell's palsy, where we can see lower motor neuron defect. Here patient is unable to have raise the eyebrow. There is no under the left side, there are no wrinkles seen on the forehead. Even the loss of nasolabial fold we can also be seen here, and the deviation of the lip is towards the normal side, because patient is not able to smile. There is no deviation of the lip towards the normal side here. So this is the case of lower motor neuron disorder, which is also called as Bell's palsy. And in this Bell's palsy patient, there is a particular phenomena called as Bell's phenomena. What happens is, when the patient usually closes the eye, onto the affected side, patient will not be able to close the eyelid normally. Has to close it with little more pressure. In this process, what happens is that we can see the rolling of the eyeball towards the upper side. So this is called as Bell's phenomena, which is positive in case of lower motor neuron disorder, also called as Bell's palsy. Now coming to examination of vestibulocochlear, which is cranial nerve 8. Here we actually do this test to check for bilateral or unilateral deafness, and any diseases which is involving middle ear or cochlear nerve. Here one important thing in vestibulocochlear thing is, one is sensorineural hearing defects or conduction defects. Conduction defects are usually related to the middle ear functioning, and the sensorineural is usually involved in internal ear, that is inner ear, especially the cochlear nerve. So both these, the conduction defects and sensorineural defects, has to be checked when we are examining the vestibulocochlear nerve examination, or any disturbance in the vestibular functions also has to be checked here. Coming to the test of hearing, first observe, evaluate hearing by whisper. First is whisper in the ear. If the patient is able to hear it properly, we can then we have to do the then it is fine. If it is patient is not able to hear those whispers properly, then proceed for next test. First is Raynaud's test. Raynaud's test is usually done to see if there is any middle ear deafness, the note is usually not heard. In Raynaud's test, what happens is we actually beat a tuning fork. The vibrating tuning fork is usually kept in the mastoid region. When this mastoid region is when the tuning fork is kept at the mastoid region, there will be a hearing sound. Patient can hear something. This is called as bone conduction. This hearing is through bone conduction. Similarly, just before the vibration is stopping, bring this tuning fork from the mastoid region to in front of the eye. Here, patient also hears. This is because of air conduction. Most of the time, or always, air conduction is heard more better than the bone conduction. If at all, bone conduction is more heard in the patient than the air conduction, then we have to think that is Raynaud's test is negative. Okay, this is because of any sensorineural defect again in the middle ear, in the inner ear problem. That is, if nerve deafness is present, air and bone conduction are reduced, but air remains always better. Now coming to Weber's test, if the nerve deafness or the sound appear to be heard on the normal ear. On a chronic middle ear disease, what happens? It is connected to the abnormal ear. Now coming to the vestibular function, observe equilibrium of the patient. Now abnormal eye movements or any dizziness, this will be helpful in identifying the vestibular function. Now coming to glossopharyngeal nerve. Glossopharyngeal nerve is again ninth cranial nerve. Here we have to test for various sensory and taste, motor function. Taste function is again, as we have discussed, test for taste by using sweet or chocolate in the anterior, that is the tip of the tongue, sour, salt and bitter. Use various food items such as lemon juice or bitter tasted material, etc. can be used for testing taste. And motor functioning. Motor functioning asks the patient to protrude the tongue, put the tongue in various different positions like touching the tip of the incisors, and lateral excursion movements can also be done. This is how motor functioning of the tongue is being checked, and also check for ability of swallowing and gag reflex. Coming to vagus or cranial nerve 10, cranial nerve 9 and 10 are together tested usually, and it is used for checking or evaluating any palate and also for contraction of the pharynx and movement of vocal cords. Here, what are the tests we do is a sensory test and motor test. In sensory test, listen to the patient talk. If there is any hoarseness of the voice, then we can think about the cranial nerve damage. And if there is in motor functioning, ask the patient to say ha. When we say ha, what happens is the free soft palate contracts and uvula stays in the midline. This is normally seen in patients. If at all there is any defect, there will not be movement of this soft palate, the posterior part of the soft palate, even when the patient says ha. Next, the common causes of the lesions, which will include poliomyelitis, and we have syringobulbia, advanced Parkinsonism, myasthenia gravis, posterior fossa tumor, etc. Now coming to spinal accessory nerve, that is cranial nerve 11. In this we have to check for unilateral or bilateral wasting and weakness of muscles. The various tests that have been done is, one is motor function, to evaluate for motor function, where patient is asked to turn the head side to side. Ask the patient to head side to side and shrug the shoulders. This is also called as shrug test. With when put the resistance on the shoulders and ask the patient to shrug the shoulders upwards. It is usually positive when cranial nerve functioning is good. If there is any defect in the cranial nerve function, patient cannot shrug the shoulders over resistance. So this is one of the tests for motor functioning. Now coming to hypoglossal, which is cranial nerve 11. Here check for the surface of the tongue. Okay, and check for any wasting or weakness and involuntary movements and voluntary muscle control. In these conditions, when patient is here we can see in this picture where there is unilateral hypoglossal nerve injury because of brachial cyst surgery. Here when the patient is normally protruding the tongue, automatically the tongue is deviating towards the side of injury. So this is unilateral hypoglossal nerve injury. And in this picture we can see a damaged hypoglossal nerve will result in inability to stick the tongue out straight. Patient cannot put the tongue out straight, cannot hold it in that position, and obviously there will be deviation to the other side. This is about hypoglossal nerve, and the tests include protrude the tongue, move the tongue from side to side with resistance. So this is about the cranial nerve examination 1 to 12, and how even we have also discussed about how various lesions will cause any defect in this cranial nerves. Thank you.